would like at first to thank my professor and my colleagues regarding this great opportunity to present such a great topic about clinical application of phospholipase A2 receptor antibodies. This is our agenda today. We will have a small introduction, and I will discuss briefly about membranous nephropathy, and then I will go through antiphospholipase A2 receptor as an antibody in the serum and the histopathology, and finally our summary and the common pitfall in clinical practice. At first, I would like to just remember everyone about the glomerulonephritis and its clinical syndromes. We have 5 main clinical syndromes in glomerulonephritis. We have what is called the nephrotic syndrome, in which the patient present with generalized edema, heavy proteinuria, and generalized edema and heavy proteinuria and hyperlipidemia. And we have also what is called the nephritic syndrome, in which the patient will present with active urine sediment, diminished GFR and azotemia, and sometimes the patient need dialysis. And we have what is called the rapidly progressive glomerulonephritis, which is called crescent PN, in which the patient will present with a rapid deterioration of GFR in days or weeks. And if you didn't treat your patient, he will be in the stage soon. And also we have what is called asymptomatic urine sediment, in which our patient will discover a symptomatic abnormality in his urine, like proteinuria or hematuria, without any clinical appropriate presentation. And we have also what is called the chronic glomerulonephritis, in which a patient will have symptoms or signs related to okay. And it's the term of membranous nephropathy. It's just a prescription of histopathological finding. It's called membranous because in the histopathology you will find thickening of the glomerular basement membrane, and there is subepithelial immunoglobulin deposits without any cellular proliferation or infiltration. Membranous nephropathy, it can be caused by primary or secondary, related to the underlying process. And we have secondary causes of membranous nephropathy. It's related to hepatitis B, autoimmune disease like lupus, and malignancy, and some drugs like non-steroid. So we have, we can imagine we have this man, which is to us clinically with a nephrotic syndrome. We did a kidney biopsy, membranous nephropathy. As I mentioned, it's just a histopathological finding. Now we have a dilemma. What is the underlying cause? Is it primary or secondary membranous? This is our question today. So once you have a membranous, it's not the final root of your diagnosis. You still have to diagnose the underlying cause. Is it a primary or secondary? And this is not only the problem here, because you can see here this published in American Society of Nephrology in 2014, that cancer risk after cyclophosphamide treatment of primary membranous, and the addition clearly there is a 3-fold increase in cancer risk once you treat your patient with cyclophosphamide. And you can imagine we have 2 main scenarios. We have a secondary membranous nephropathy related to malignancy, and you misdiagnose this case as a primary membranous, and you treat it with cyclophosphamide, which is already increased the risk of malignancy 3-fold, and this is the result. Or you have a case of primary membranous, and you treat it with cyclophosphamide or another immunosuppression, and it switches from primary to secondary. one day I was informed by my professor, primary and secondary membranous nephropathy is crossed by each other. It may be present like primary and it turned to secondary, or it may be primary, secondary, or present as a primary. This is not only the dilemma we always face in membranous nephropathy. We have also regarding the toxicity of the drugs and the natural history of the disease. We should all know that spontaneous remission occur in around 30% of cases in 5 years. So spontaneous partial remission occur in 30%, almost 30% of patients at 5 years, and around 5% of untreated patients will develop end-stage renal disease. But if the patient remain non-nephrotic range that whole duration, the risk of end-stage after 5-10 years, it will get to low up to 2%. So again, as we see here, the progression, the partial remission or complete remission with time usually occur with primary members. So we have another dilemma here, eat or wait and see. Because again, as we mentioned before, treatment is associated with multiple risk, a case of malignancy, and we have to decide the nature of the disease. As we mentioned, most of the cases will develop a partial remission or complete remission in the 5 years. So this is our topic today. We will discuss again, as we mentioned, this antibodies, what is called the anti-phospholipase A2 receptors antibodies. Regarding this is our glomerulus, and as we see here, this is a filtration barrier of our kidney, which is composed of 3 main compartments. Number 1, we have the capillary endothelium, we have basement membrane in the middle, and we have the podocytes. Podocytes have on its surface what is called the phospholipase A2 receptors, and this is an antigens which is the target for specific antibodies, which is called anti-phospholipase receptors antibodies, and this is the cause of primary membranous. So in 2009, this antibodies was diagnosed, and it's IgG antibodies against this specific receptors on the surface of podocytes, and it can cause, as I mentioned, idiopathic membranous nephropathy. In 2011, as a genome-wide association study confirmed there is an association between primary membranous and phospholipase A2 receptors antibody related to HLA class DQ1A1. And in 2013, the first ELISA test for assaying the antibodies was reported, and in 2014, the major epitopes was diagnosed. You can imagine in just a few years, KDIGO guidelines in 2022 stated that kidney biopsy is not required to confirm the diagnosis of membranous nephropathy in patients with nephrotic syndrome and positive anti-phospholipase A2 receptors antibody in the serum. So it's a whole revolution in just a few years. And we can see here there is a systematic review discussing diagnostic test accuracy of serum anti-phospholipase A2 receptors antibody and the glomerular phospholipase A2 receptor antigen for diagnosis of primary membranous. And as a result, sensitivity is around 80%, and specificity is around 97%. And again, I just wanted to take 1 to 2 seconds just to focus in the term of sensitivity and the specificity. So the meaning of 80% sensitivity, this means still you have 20%. It can be diagnosed as a primary membranous, but the test is negative. Specificity is around 97%. This means you still have 3%, which is can present with anti-phospholipase receptors antibody positive, and it's not a primary membranous, it's secondary membranous. And also we have the analysis of the results showed a prognostic value of the test. So you can see here, once you have a high level of anti-phospholipase A2 receptors antibody in the serum, it can be associated with high risk of progression and low risk of spontaneous remission. On the other hand, if you have a low titer or absent antiphospholipase A2 receptors antibody in the serum, it is associated with higher likelihood of spontaneous clinical remission. And I want to stress in the word of absence. So still, absence of antiphospholipase A2 receptors antibody, it doesn't exclude the disease. It may be a good prognostic factor, but you have to go through the case and then you have to make sure this is a primary membranous. And finally, if the reduction in antiphospholipase A2 receptors antibody level within 6 months after diagnosis, with or without treatment, it's commonly associated with clinical remission. However, there is a problem here. The threshold used to define was a high titer varied from study to another. And still remain unclear what is the specific titer considered as a positive or negative, or considered as a significantly positive prognostic factor, as we will see later in the guidelines. Okay, so antiphospholipase in serum, this is our topic. So regarding the availability of tests, we have here 2 tests available in the market. We have what is called cell-based immunofluorescent assay, and we have also the ELISA. And both of them detect IgG antibodies against phospholipase A2 receptors antigen. And according to the manufacturer structure, immunofluorescent assay considered as positive if you have a titer from 1 to 10. And for ELISA, it's considered as positive if you have a titer above 20 relative unit per ml. And consider a borderline if the result from 14 to 20. And it's considered negative if below 14. And this is many clinical laboratory or even publication used this cutoff as a seropositive or seronegative. And in comparison between ELISA and the indirect immunofluorescent assay, it shows immunofluorescent assay, it's maybe more sensitive in the detection of the antibodies than the ELISA, especially when we use a cutoff positivity more than 20. And several centers for this using both ELISA and immunofluorescent assay to confirm seropositivity. And in cohort study, including 480 patients, all of the patients tested for antiphospholipase A2 receptors antibody by both techniques. There's 110 cases considered as a seronegative by ELISA and diagnosed as a primary membranous by the gold standard, which is the kidney biopsy. And in comparison between ELISA and immunofluorescent assay, there is a 30 cases which was ELISA negative. It was positive in immunofluorescent assay, and all of them was primary membranous compared to the gold standard, which is kidney biopsy. But there is also 80% negative, both of them, negative ELISA and the negative immunofluorescent assay, and still diagnosed as a primary membranous based on the kidney biopsy. And regarding the immunofluorescent assay or the antiphospholipase antibody screening in the biopsy, I just want to focus on another point. We have in histopathology 5 basic stains, which is considered for all cases. If you have a case, you did a kidney biopsy and send it to a histopathologist, he will just do the routine basic staining, which is include hematixin and eosin, hepatic acid shift, trichrome, silver stain, and Congo red. This is a basic staining. But if you didn't ask for a staining for antiphospholipase, he will never do it. So please, just if you are suspecting a case of primary membranous or secondary membranous, you have to compare or you have to diagnose, you should ask your pathologist regarding doing the antiphospholipase receptor staining in the histopathology. And also I want to focus on another point. You have for diagnosis, you have to stress on the type and site and pattern of the finding in immunofluorescent. So you can see here in primary membranous, you should have IgG4 as a deposit in your histopathology, and it should be around the capillary loop, and it should be also a granular deposits. There is staining for antiphospholipase A2 receptor available in the market, but there is another antigens. It can be screened, and it's also associated with primary membranous like thrombospondin, serine protease. It's also associated with primary. But in secondary membranous, you can see there is another antigens can be screened like exostostine 1 and 2 and the neural cell adhesion molecules and type 3 transforming growth factor, but most of them is not available in all histopathologist lab, and specifically in expert labs, and it's all usually seen in lupus nephritis, membranous secondary to lupus nephritis. Of you have, again, if you have full house like IgG, IgM, C1q, this is suggestive of class 4 lupus nephritis. If you don't have IgG4, but you have IgG1 or IgG3, it's more common to see with lupus. If you have IgG1, IgG2, it's more common related to malignancy, secondary membranes related to malignancy. The site changed from the capillary loop to be seen in the tubular basement membrane. This is mostly related to lupus nephritis, not to primary membranes. So again, it should be IgG4, and it should be around the capillary basement membrane, and it should be the pattern. It should be a granular deposits. Any change, you have to consider a secondary diagnosis, not a primary membranes. Now we have to go a clinical application of this this antibodies. We can use it in diagnosis, and as we see here, this is guidelines in 2022. For all patients suspected membranous nephropathy, you have to do serum PLA2 receptors antibody test. But again, as we mentioned, because this test is not 100% related to primary membranous, and you still have 3% related to secondary, you have to go through the case. You have to exclude all the secondary causes, like you have to do ANA, you have to do screening for hepatitis B, hepatitis C, HIV, complement system, serum electrophoresis, serum immune fixation. So you have, again, to exclude secondary causes, and because, as we mentioned, there is cross reactivity between primary and secondary membrane. And the most important question is, if we have a primary, if we have membranous based on histopathology, and we have antiphospholipase receptor antibody positive, the question is, do we need still to do a kidney biopsy or not? There is a debate, but most of centers, once we have no obvious secondary causes, no diabetes, no atypical presentation, and GFR is more than is normal GFR, there is no need for kidney biopsy. Diagnosis can be based on serum antiphospholipase in the serum and excluding of other secondary causes. If you have abnormal GFR, if you have suspicious regarding a secondary disease, patient has diabetes, atypical presentation, so kidney biopsy can be considered. And according to the finding, it can be phospholipase positive in the pathology, and now it's a primary membranous based on serum and histopathology, and you can start treatment, or you can decide what is your management. But if the pathology showed another finding, now you have to screen for the other causes of secondary membranous. And just a small box, we still have phospholipase A2 receptors antibody negative in post serum and histopathology, and we will go through how to diagnose such cases. Number one, as we mentioned before, the type, the pattern, the site of immunoglobulin G deposition. If it's immunoglobulin IgG4, this is mostly related to primary membranous. If it's mainly, if we have another staining like thrombospondin, it goes with primary. But if it's IgG1, it's mostly related to secondary. And if we have what is called the mass spectroscopic analysis, it can help in diagnosis. So in phospholipase A2 is not a perfect test, but it's a very useful test in the diagnosis. Regarding clinical application of this test in and risk assessment, as we can see here, we can divide our cases into three main categories. We have considered our patient as a low risk, and we can consider it as a moderate risk and high risk based on three main risk factors. Number one, antibody to receptors antibody titer. We have proteinuria. We have the polymerase rate. If you have a high titer of antibodies, heavy proteinuria, and low GFR, this patient can be considered as a high risk, and the opposite, it can be considered as a low risk. And this is from guidelines 2022. You can see they are dividing the patient to four main categories: low risk, moderate risk, and high risk, and very low risk, very high risk. And this is based on, as I mentioned before, the main three categories: GFR and proteinuria and antiphospholipase titer. I just wanted you to look in the third table, in the high risk table. You can see the titer in the prognostic factor of antiphospholipase A2 receptors antibody. It's considered a very prognostic factor once you have ELISA titer more than 50. So it's they use a cut of 50, not a 20, to consider it as a prognostic factor for risk of progression, not 20 for diagnosis. Also, regarding treatment, after you subdividing your patient according to the risk factor to low risk, moderate risk, and high risk, and very high risk, you can consider wait and see for low risk patient. You can consider rituximab and calcineurin inhibitor for moderate or high risk patient, and you can consider cyclophosphamide or Ponticelli regimen for high risk and very high risk patients. Not only this, we can use a response to treatment after 6 months if the patient received one of the regimen like rituximab or cyclophosphamide or calcineurin inhibitor, and after 6 months you trace the test, you repeat it, and it's become negative. Now you can downgrade your immunosuppression. If it's still positive or is still persistently high, you can switch to another regimen. If you started with rituximab, you can go for cyclophosphamide, or you can continue rituximab. And if you have started with calcineurin, you can switch to another potent drug. And if it's decreasing, so you can start to downgrade your immunosuppression. Also, I just wanted to again focus, if the patient is not responding, don't forget, it can shift from primary to secondary. So if you are seeing your patient not responding to treatment, you have to consider re-evaluating your case. Finally, in our kidney transplant patient who developed end stage, and you wanted to counsel him regarding the risk of recurrence, you can use both serum and kidney staining for antiphospholipase antibodies to divide our cases to high risk and associated with risk of recurrence around 50%, and medium risk, which is associated with 30% risk of recurrence, and low risk, which is associated with 10% only risk of recurrence after transplantation, and it can be useful in your patient counseling in kidney donor clinic. So we, as I mentioned in the start of this presentation, we have two main dilemma. Once you have a patient presented to you with a nephrotic syndrome, and you did a kidney biopsy, which is showed a membranous nephropathy, and now we have a diagnosis regarding a primary or secondary. For all cases, you have to do phospholipase A2 receptors, the antibody in the serum and in the pathology. If you have a positive phospholipase in the serum and the pathology, you still have to exclude all secondary causes. If secondary cause is negative, now you can diagnose your patient as a primary membranous. Otherwise, you can diagnose your patient and as a secondary membranous. Regarding treatment or treat or not to treat, you have to classify your patient based on antiphospholipase receptors antibody titer in the serum or in the serum. You have to know his GFR, level of proteinuria, and after dividing your patient to low risk, medium risk, and high risk, and very high risk, you can decide regarding the best regimen for treatment, or you can consider your patient as a conservative management, and you can wait and see. Primary and common pitfalls in our cases. Number one, where usually we patients who are diagnosed as a membranous nephropathy still should undergo age and appropriate risk screening, cancer screening, if already not performed, even if he have a antiphospholipase receptor antibody positive in the serum or in the pathology. Diagnosis of primary membranous should not promote extensive search for occult malignancy in the absence of some suggestive findings, such as extensive smoking history, GOEC positive stool, unexplained anemia or weight loss. Although microscopic hematuria is a common finding in membranous nephropathy, but some centers used to do cystoscopy to exclude cancer bladder for cases before starting treatment and before considering our case as a primary membranous. As we mentioned, still require cancer screening, but at the same frequency as a general population. Antiphospholipase antibody test is negative, or the histopathology is consistent with secondary membranous, and there is no other clear cause of secondary membranous, such cases require more frequent screening, especially if not responding to treatment, if you consider it as a primary membranous, because you can't find any secondary causes. And you can see in one study of patient biopsy probing membranous nephropathy and negative test for serum antiphospholipase A2 receptors antibody, considered have around 10-fold higher risk of malignancy, and the increased risk of cancer screening. Frequency of cancer screening should continue from 5 to 10 years after the diagnosis of membranous nephropathy, since the cancers associated with membranous nephropathy are typically diagnosed within this time frame. And finally, positive for antiphospholipase doesn't totally replace the kidney biopsy, especially if you have a patient with abnormal GFR, a clear secondary cause, or diabetic patient, or those patients with atypical clinical presentation. And finally, I would like to just focus in this picture. All of us need money, asking for money, but we should know, don't forget, learning is the only treasure that will travel with its owner everywhere. And thank you.